decision-making tricks, and I show many cases, and I just want to discuss with those cases this important problem. But first of all, as we all know that the problem with the congenital scoliosis, especially because it's an early onset problem, as you all know that the early onset deformity means the starting of the deformity before the age of 10. This is important because of the pulmonary development. So if we have a good mature pulmonary function and the mature lungs, and then we can actually do our straightforward surgical treatment to this kind of patients. But before the age of 10, we need to allow the lung maturation, of course, together with the chest development. You can see that here is a very well known the development of chest diagram. As you can see that in the newborn is almost 6% of the adult life, or the chest development is already exists, and then in 5 years old is 30%, and then 10 years of age is 50%. And this is the adult, the 100%. And this diagram also shows you the sitting height change. That means between the T1, L5 change during our development, which is very important. That's why we need some kind of growth guidance in early onset problems. How scoliosis affect our thoracic cage, you can see here. In not only actually a coronal plane problem, but also together with the sagittal and horizontal diameter of chest decreased by the scoliotic deformity. And of course, because of this kind of distortion, there is a rigidity of rib vertebral complex. Also intercostal muscle dysfunction, together with the chest asymmetry, and all of these problems actually decrease the chest expansion. We have some treatment options for this problem, but we need to know patient maturity, as I mentioned already. We need to know cure magnitude, also type of scoliosis, and if there is any intraspinal pathology or not, like diastematomyelia or the tetrad cord or KR malformation, so on. And these are very important for our decision making, and then we may follow the patient. We may apply conservative treatment or surgical treatment. For the conservative treatment, unfortunately, it's very limited in the congenital deformities, but sometimes, in order to postpone to surgery, we may put the patient in wrist recast or brace treatment. You can see that here is a frame for the wrist recast. In recent years, especially after the 2010 or maybe 2005, many centers, deformity centers in all over the world, they started to again wrist recast. And as we all know that this is a kind of historical actually treatment method, but now it's again is popularized by the many surgeons, and is really important for the early onset scoliosis. Brace treatment is also very, sometimes we need to do. Let's say in 9 years old, 50 degrees curvature, we may put a cast, in a wrist, in brace treatment, it's a kind of TLSO, and for the time being, this is important for the cure progression. When you look at the principles of surgical treatment, of course, risk of neurological complication is very high, according to especially mortality and morbidity reports of the Scoliosis Research Society. So we need to have routine full spine MRI, this kind of patients, and sometimes we need to do early and aggressive treatment in some special circumstances. Of course, neuromonitoring is essential. In any deformity, we need to do neuromonitoring, especially this sometimes is congenital case have some kind of motor problems, some neurological problems. That's why in neuromonitoring team should be expert on this kind of cases. And during operation, we need to prevent hypotension as you all know that before the 2000, most of the centers, they are doing the hypotensive surgery in order to prevent the blood loss during the surgery, but we at least we need normotensive anesthesia if during the deformity, especially corrections and osteotomy and so on. Distraction maneuver sometimes dangerous. We have different kind of options, many options, and we can start with the safer one, which is the in-situ fusion. Sometimes we are doing like that with the in-situ fusion, and you can prevent the curve progression. But if you are doing this in-situ fusion before the closing of the Y cartilage, visit the acetabular cartilage, or before the maturation, and then you may have crankshaft phenomenon, which is a kind of a recurrence of the deformity, I should say, especially if you are doing the posterior spinal fusion. Then you fuse the posterior side, but the anterior part of the anterior column still growing, and then we may have crankshaft. It's a kind of rotational deformity. We can do convex hemiepiphysiodesis. This is not that actually common in these years, but it used to be very popular. But the problem with the convex hemiepiphysiodesis is unpredictable. So you cannot predict that it's going bad or going good. So it's so difficult to actually for the decision making. Some of the straightforward surgeries, one of them is the hemivertebral excision. If you see the hemivertebra, especially located at the lower lumbar and sometimes thoracolumbar junction, then if you excise this one, and then you can prevent earlier the curve progression. But when we look at the McMaster series, natural history is different and change according to anatomical localization of the hemivertebra, especially in the upper thoracic spine, is not that bad. Actually, if you see that the upper thoracic hemivertebra, you can follow it, this kind of patients. And then most of them doesn't have a big, actually, curve progression. Another important, very important option is the growth guidance methods, like growing rod or Vaptor. These kind of methods are very important, as I mentioned before, because most of the case has early onset. So we need to actually allow the spine grow and then chest become mature. And of course, it affects lungs obviously. And sometimes we need osteotomy and fusion for neglected cases, and we can treat this kind of cases. I would like to give some case examples, because you cannot say that these are the indication and these are not. So this is not a kind of, we don't have a recipe for all of the cases. But I would say that if you have a hemivertebra problem, you can go and then just take out the hemi, and then this is already solved. So you can prevent big problems. This is 4 years old lady, and she had a lumbar curvature. She intact neurologically. You can see here there's a scar just the lower part of the lumbar area. This is because of she got a diastematomyelia excision 6 months ago, and you can see here obvious pelvic obliquity and ipsilateral hemivertebra at the bottom of lumbar spine. If we say that, okay, let's follow this patient till to becoming like 12 years old and then do the surgery, it's become a horrible actually curvature. So we need to manage this problem by now. Otherwise it creates big problems. But of course, the ipsilateral hemivertebra excision is not that easy, especially in the lumbar spine, because there should be 3 roots at the left-hand side, should be in one foramina. So we need to do a good actually foraminal how to say, foraminoplasty for this kind of patients during the surgery, and we need to take care of the no roots at this site. This is the pre-op MRI of this particular patient before the diasto excision. Yeah, actually we did ipsilateral hemivertebral excision from the left side. You can see that with the one level above and below fixation, and you can see that the pelvis is level now with the shoulders. Before it's like that, like something like 40 degrees or maybe a bit more. There's a pelvic obliquity, but now it's level. At this stage, we solved the problem, and this is the 3-year follow-up of this patient. We're still following up this patient, of course, until the maturation. We may have some kind of residual curvature curves or some kind of adding on phenomena for these patients. This is another one, 4 years old, again, young boy. This patient have contralateral hemivertebra in thoracolumbar junction and lumbar spine as well. So we think that if we actually, as you can see that these hemivertebras balance to each other. If we wait for this one, let's say for 10 or 12 years old, and we need to fuse all of the spine of this young boy. So we decided to do both hemivertebral excision for both levels for this particular young patient. And you can see that this is the 6-year follow-up of this patient, and then the alignment is acceptable for this young man. This is another one, 8 years old. Again, she had diasto at the thoracolumbar junction here, and then actually already excited by our neurosurgical team 6 months ago, and there's no neurology. Here, as you can see here, there's in diasto level, there's a huge congenital problems here, and posterior arcs already that not exist, and then we actually think about what we can do for this immature patient, and you can see that is also is not that flexible curve, and we do a grown growth construct because the cost of the major growth. During that time, I tried to do one major growth for these patients because it's very expensive, and some of them failed actually. But this patient is not failed, and then we actually followed this patient until the maturation. As you can see that I didn't open this side. I put a foundation here, another foundation top, and then connect them with a major growth subfascially. This is the post of 1 year. You can see that there is a little bit truncal shift, but still acceptable. And at the post of 3rd year, there is still truncal shift, and we did a graduation. She was 11 years old, and acetabular cartilage already closed, and then we can do safely our graduation operation. And this is the last operation of this young lady, and then you can see that is already balanced spine. This is another one, 4.5 years old, this young lady, and she suffered from meningomyelocele. It's a very typical patient. She had a lumbar kyphosis, and together with the thoracic hypokyphosis. Of course, she needs to sit erect position. In order to sit erect position, she needs compensation. That's why she had this kind of lordosis, maybe hypokyphosis or lordosis, we can say. And she's a non-ambulatory paraplegic patient, and of course, for this kind of patients, it's easier to do operations because there is no dura. Dura is actually end by this level, somewhere here. It's upper lumbar spine. And you can see that the X-rays and lateral traction X-rays of this young girl. This is the 3-dimensional CT scan. You can see that there is no arcs, especially lower lumbar spine, just skin and subcutaneous tissue together within the canal. So if you open this one, you can easily do your osteotomy. It's like a femoral osteotomy actually. It's not that difficult. But our plan, we think that her chest, because of her chest development, we need to do a kind of hybrid approach for this young lady, because if we are doing osteotomy here, is okay, but what about the hypokyphosis or lordosis of the thoracic spine? She needs a major lung. So that's why we put a groin growth construct at the top. We mixed two operations, and then this is our early post-op. You can see that she can sit in erect position, and we are doing the groin growth at the lungs, but we fixed this place. But the life is not that easy for this kind of patients. We have many skin problems at this time. As you may actually guess that she already have a flaps here because of the meningomyelocele excision during her newborn infant period, and then her scars is not that, I mean, skin quality is not good, and then that's why we have many problems. And I would admit that actually we follow this patient 6 months with the in this position, because many flap surgeries we had, and then plastic surgeons say that if we are doing too much flap surgery, we can not do anything at the end. So we just actually the parents are very cooperative. So we ask them, if there is any infection exists, then you please bring us your kid, and then we can do something for her. But we follow like 6 months, maybe 1 year. In this position, we open this side, and this side already open our domino, and then we can easily lengthen this patient from here. This is another one, 2 years old, and this patient doesn't have any intraspinal pathology, but she looks balanced, but her curvature, especially upper thoracic curvature, is huge deformity. And as you can see, that it's not that actually flexible, and we thought that if we wait for this actually problem, then we create more and more big problems. So we need to actually do everything at this stage. And then we did a kind of hybrid operation here. We did a convex hemiepiphysiodesis here, groin growth together. And we try to actually stop the progression at this convex side, and then try to lengthen and distract the concave side. This is our actually plan. In this plan actually worked for 2 years. As you can see that her balance is not bad, is okay. Still we are lengthened, but at the end he developed a kind of actually fusion here, and we saw that we cannot actually distract the patient. So we did SPOs at this level, at the apex, and convert her actually construct is a classical groin growth construct.